cost savings. Okay? So I think we need to communicate to the doctors, and we need to communicate to them that, in fact, getting off the fee-for-service treadmill, that's actually going to be a really good thing for you. You're going to be much happier. Here's my last point about optimism there. Some of you may track or may see or may notice there has been a recent crossing of the lines and trends, which I think is inevitable to continue. The number of self-employed physicians versus the number of employed physicians has recently crossed within the last year. Really good indicator. Most of us in this room don't want to go out and have our own practice, be a onesie or twosie, and do all the headaches associated with practice. We are going to employment. And I think that's going to dramatically change how we see our work environment, the kind of environment we want to create, and in fact the kind of satisfaction if you get into a good environment versus a bad environment. And that, again, I think is going to be a very important change. I would say that that's probably been largely catalyzed by more women in the profession, A, and B, more women married to more men in the profession, where they're not allowing their husband to be maniacal and work 80, 90 hours a week.
Time for one more question.
That's a lot of pressure.
You can handle it.
I'm Maggie Kozel from Rhode Island. And in Rhode Island, you definitely wouldn't want to take bonds out of hospitals. Several of the hospitals there are in serious trouble. But one of the trends that's happening there that I think is probably happening in a lot of places is that hospitals are now sort of extending themselves out more into the communities, providing primary care, outpatient services. As you were just referring to, many docs, especially in primary care, are selling their practices, becoming employees of the hospital. But I guess my question is, when you listen to them talk about it, because they sort of market this, and probably are the biggest advertisers on billboards in Rhode Island, one hospital competing with another for patients. And it starts to sound a little bit to me like Walmart's going to figure out how all of us don't need to use as much detergent. I guess I'm wondering, is this really, can we have confidence that this can be a step forward? Because it seems like there's a sort of inherent conflict of interest.
Well, I'm not exactly sure why they're competing like that, except I would suspect that their occupancy rate each is pretty low, and if it goes too much lower, then one or the other is going to be out of business, and that's why you get a lot of competition at this moment. But done properly, and again, not every hospital moving further out into the outpatient setting is going to be done properly, but that is inevitable, it seems to me. If you're going to decrease hospital admissions, one of the ways hospitals are going to make up revenues is by increasing outpatient activity that is cost effective. Now, a lot of them are simply transferring things to the outpatient setting where there are high prices, lower fixed costs, and they make more margin. But I do think that, again, the most interesting cases are going to be the cases where you've got much more seamless coordinated care, inpatient, outpatient, with a bigger focus on keeping patients healthy and in the outpatient. I think that's the inevitable path. You can do it without hospitals buying practices with more coordinated care. There's a really good example in Sacramento between Catholic Healthcare West, a hospital system, Hill Physicians working in Sacramento, where they never administratively or financially merge, but in fact they have coordinated care to reduce unnecessary costs and share the savings. That, if the latter direction is the one most places go, I think it will be better. Again, a lot of this depends on our moving off a fee-for-service payment system that only rewards doing more and doing more where the margins are highest. And I think, we have to do that. I would say that is the place for doctors to take the lead. It is going to be very difficult for Medicare to invent bundles all by themselves. Insurers are doing it, but this is a place for doctors to take the lead. What is the bundle to be paid? What is the necessary care? What is the care we're going to leave out of that bundle because it's really unnecessary for the vast majority of patients? That's an alternative payment method, and it incentivizes doctors to be a lot more efficient and to think very carefully about the right treatment. And it's best done by doctors. But if we don't take the lead, I can tell you, someone else is going to come in and impose it on us. Anyway, thank you for coming together, taking leadership on this. Good luck.
Thank you very much, Dr. Emanuel. At this point, I think we're going to be introducing our next panel. Dr. Emanuel highlighted many of the positive aspects of the Affordable Care Act moving forward. The next panel will be discussing some of the challenges of full implementation. To introduce that panel, I'll have Nick come up to tell us about the panelists and set the stage.
Good morning, everyone. Our next panel, our plenary session, is entitled The State of the ACA, Impact to Date and Challenges Ahead. So I'd like to invite our panelists to join me on stage, please.